Hello, everyone. So we are going to start a new session. I'm Dr. Sehrish Abrar, and I'm a radiation oncologist working in Pakistan. So yesterday we left a talk by Dr. Abdulaziz Alnajjar. So we are going to do that, and then we will follow the regular program. So it is my pleasure to introduce our keynote speaker, Dr. Abdulaziz Alnajjar, the professor of clinical psychology in UAE. Dr. Alnajjar holds a PhD in psychology from the University of Durham in the UK. He currently serves as a research team leader at ARA Consultancy and as a contracting lecturer at the Mohammed bin Rashid School of Government. He's a pioneer of the AI-based self-insight treatment tool developed through his innovative care therapeutic approach and is a recognized leader in the clinical psychology. Please join me welcoming Dr. Ahmed Abdulaziz Alnajjar to the stage.
Thank you. Thank you. Good morning, everyone. Assalamu alaikum wa rahmatullahi wa barakatuh. I don't feel little comfortable because I'm not talking with my usual group who I talk with. As when Dr. Nadeem asked me to speak about psychology, about cancer patients, I told him, okay, but where's my audience, my usual audience, my playground? But by time when I attended the first sessions or the first day, I felt that I'm at home because we are talking about the same subject. We are talking about the same people. We are talking about one concern, which is how to take care of our cancer patients. And that's why I felt more comfortable, but at the same time, I feel that it is the subject which I'm going to speak about is some kind of challenging subject. Usually, if I'm coming to a new location, it's traditionally, we speak about how could we cooperate, how could we make research. But this time, I try to think, how could we try to understand patients, cancer patients, in a different way? So I use different lens. Today, I will talk to you in a different way. Maybe you will not find somebody speak about it through my experience of 25 years dealing with clinical psychology. I thought that there is a huge starting point mistake, which is that we consider cancer patient as psychologically ill, which is supposedly not. Supposedly not. Why supposedly not? Because traditionally in our psychological pathology, we look to people whether they are mentally well or mentally ill, psychologically ill or psychologically well. And when we look to them in this casual categorization, we depend on the three criteria, which is how long, the long-standing vulnerability, the gradual symptom, usually symptoms comes gradual, does not come all of a sudden. And at the same time, supposedly there is internal causes like developmental issues, there is developmental issues, maybe personality issues. So there's too many reasons make the psychological illness comes gradually until it appears or become patient. But here in cancer, it comes all of a sudden because it's grieving, life is a threatening situation. And that's why the problem is that when we come to our usual criteria, you know, in psychology and everywhere, you have your own criteria. In DSM-5, we use it, and ICD-10, 9, 11, whatever, and CCDMD, this is the Chinese criteria. They use the CDMD-3, yes? Yeah, and all of them, they will say that that cancer patient is psychologically or mentally ill. How come? Why? Because of one reason, is that our criteria our psychological screening, our psychiatric screening, all comes telling that he has psychological issue. That's what we call this disorder. But the point is, when you say he has psychological disorder, it does not mean distress. I mean, when somebody is distressed because, oh, somebody told me or the doctor told me you have cancer, so I'm grieving. I don't like to see people. I want to go hidden a little bit. I feel depressed a little bit or more. Am I going to be patient? That's the main argument which we are talking about. And I think that understanding this point will affect all our treatment even, or how we deal with patients. And I call it response. And this is one of the main problem. I think that it would affect the way how we look to the psychological cases, and from the cancer point of view or the psychological oncology, and we need to understand it very well. Usually, as we say, that often that patient, that cancer patient, is psychologically stable before he be notified that he is patient of cancer. Socially functioning, occupational successful, emotional regulated, and identity. Oh, but all of a sudden, he had the life-threatening. He is going to face some loss of bodily trust. Even he lost trusting his body. How come he's not going to be grieving? And that's why I think that there is a new psychological category ought to be seen or observed or taken care of when we deal with cancer patients. And this made you think that maybe this argument is not important, or maybe somebody, but I'll tell you that there is very core clinical challenges because of this misunderstanding or misperception. Because when we speak about injury, we talk about sudden, as we said. When we talk about illness, it implies some history of incidents. But in cancer case, we need to deal with them in different way. Containment, stabilization, meaning reconstruction, more than treating them in our usual clinical treatment techniques. And that's why I can't say that cancer patients are not psychologically ill. No, they are more psychologically injured, the same way as we go to hospital and you are injured with something, nobody will take from you any kind, use any kind of other check techniques. Let me give you an example of this. Only the moment where you've been told, I mean, not you, God bless everyone, somebody being told that he is going to be cancer patient, he will be shocked. Then he will deny. See how many stages, psychological stages he is in. Anger, little bit, fear, more, depressed. Then he will go getting to be exploring decision and try to face his situation. And that's why I can say that all of those turmoils happens because of one information that you are a patient, a cancer patient. Another thing, actually, when we look to the patients of cancer, you will find something else, which is through the stages, through his journey, cancer journey, actually, he will face many different psychological issues or strains. An example, usually we categorize them to 4 stages, like doubt stage, shock stage, treatment stage, recovery stage. But however, every one of those stages has its own sub-stages. I mean, long. I mean, like to say, when you speak about treatment stage, it is like, how long? How many times? Or he's going to be chemo or radio or operation or so. Actually, it takes a lot of timing, plus that it is, as I call it, psychologically dynamic and multi-stage psychological journey in every stage. He has some kind of feeling, whether depressed, the other stage is strained, the other stage is having anxiety, then post-traumatic, whatever. So the problem is that we are in psychology, we deal with it in a way that we are not understanding the journey itself. If we understood the journey of clinical, from a clinical point of view, we are perceiving the journey of cancer patient, we would understand that we are doing a big mistake in dealing with patient by judging them. You will be shocked if I told you, if I am a classical clinical psychologist and a patient came to me and he's little depressed and he told me that he is cancer patient, you know how I will categorize his case? I will say he is MDD, which is major depressant disorder, the highest neuropsychological case, which is not. It is situational. When it is situational, would it be considered as a case? That's the subject, and that's the consequences. The consequences, dear brothers and sisters, is when we look to psychology and try to deal with that case, we treat them as a one condition case, which is wrong. He is cancer patient, he has multi-stage psychological strains, so he has to be taken care accordingly. And there is too many intervention. Sometimes they refuse to cooperate with us as a psychologist because they want to be with themselves and they know how to deal with it. And they are waiting for a treatment and they know that this time will pass away. So the feeling will pass away as well with the circumstances, but the problem is we will consider their resistance as non-compliance, which is wrong. And also we have another problem, which is the aging, or we usually end our treatment as the treatment ends, which is another strain here. You see that most of the cancer patients, after they survive, done with their treatments, and they survive even 5-6 years, and still they are sensitive with this case, or what would happen to them. They fears because, most of your explanation will tell them that, oh, be careful, it might come again. There is 70% of people who have had already cancer, they will get it again. So that's fearing situation ought to be as well taken care of. This affected our treatment. This affected the way how we deal with them, but I will not spend time in this because of the timing, because it is vice versa, and I will come to the solution. From my point of view, this solution will help me, will help you, will help everyone deals, even families, even the people who are related to the care of cancer patients, even for those who are thinking to build the department for care, to care of cancer patients. I say, let us go to it or deal with it in the following ways. One is when a cancer patient come to you, you never put him in that criteria, whether he is well or ill. Ask different question, which is what type of psychological condition he is. Why? Because yes, there is psychological cases, but not for the most of them. Most of the patient, let me say, as we observed, 90% of patients are injured. They are in a shock status, but not the usual shock status that we speak about it. It is like long-term one. Yes, there is people who has the vulnerability and they might get sick psychologically. So we need to identify those people. We need to identify those who has already have previous case of anxiety and became sick. That's another kind of treatment to them. And there is, don't forget, the iatrogenic effects of medication. Some might have throat, I mean, well, I forget the name of it. شو اسمها الغدة النخامية? Yes, they might have some, the gland. Thyroid, yeah, thyroid. You know, sometimes you get stuck with words. So the thyroids, you know that it is most of the most gland affected because of the medication is this one. The thyroid, if it has a problem, you will be aroused, goes to anger more, and by that you have to understand there's lack of medication, lack of vitamins, lack of minerals, some other problems comes because of this. So this is not psychological case, this is medical case. So we need to identify even the survival case. So when you want to understand that person, I will not say that sick person, sick from the cancer side, but from psychological side, you need to look at the case and try to find out which level or which category you can allocate him, taking care that it is not he is not automatically sick. This is one part which is very important when we deal with him. The second part is our goals. What do you want? What shall we do with that patient if he is injured, not if he is sick? I'm talking about the injured people. I think that we have 5 S's. We need to concentrate on trying our trial to stabilize the case until he finish, until he's done with the treatment, or strengthening him, whether he needs support, we do the support, or when he needs sustainability, we deal with him in a sustainable way. So those are our goals. Everyone can do it. I can do it. You can do it. Doctor can do it. Nurses can do it. If we are all in this target doing what we want, he don't need treatment because he is psychological ill. Third point is the services we provide him, and that's ought to be taken care. Like emotional regulations, cognitive support. We need behavioral guidance. Sometimes they need behavioral guidance to deal with situation and extra of those services. I experienced some cases, cancer cases, and some of them came to me as cases. So as Ahmed, I have my own theory. I have my own psychological approach. I call it sometimes silent approach, silent treatment. I mean, when you have psychological case who has cancer, he don't want to talk. He wants to be relieved. He wants us to reduce his strains. He don't want to express his fears. And that's very important, because that part of respecting the dignity and the individuality of people. And that's why we deal with people in a different way. We have our own SITT technique. And in this self-identification technique, and we go with people in 3 levels: clean the negative ideas, aligning, making his mind works, and restoring to restore coherence. Because as you see, in psychology, mainly we care about the psychological indications, behavioral indications, and sometimes we use some kind of like physical tests like EEG. And in EEG, we found out that most of the cases, their mind waves is like goes alpha, beta, theta at the same time. And those cases needs alignment. As Egyptians say, شو عقله يودي ويجيب كيف يترجمونها ما أعرف. His mind goes like just what's psychotic, but it's not like a turmoil. He don't know. He cannot concentrate. He cannot express himself, forgetting things. He cannot focus. All of this comes in the same way. So that's why we deal with him without medication, we deal with him in a way that helps him to align. And then we help him in resilience and then endurances, which will help him by time. Let me say that everyone has his own mindset. Everyone has his own way of thinking, his own way of dealing things. And now in psychology, too many things became different than before. Before we've been talking about IQ, EQ, and those things, I mean, intelligence and emotional intelligence. Actually, now we don't judge people according to how clever they are. We judge people according of how their mind is controlled and their awareness of the mind, how it thinks, what we call it mind governance and resilience. How you are aware of your ideas, of your thoughts, you will be able to control your thinking, your feelings. And how this treatment comes in this way, like when somebody has psychological oncology, a problem, a reality, he will face some fears. So we use our care, then it will come with nonverbal. You can read it yourself because I felt that I'm little spending time. I don't know, they did not give me the count or I passed over it. Okay. You know, when you talk, you didn't concentrate much. Okay. Takeaways for all of us, which I like to focus on. 3 bullets. I wish everyone concentrate on this slide. 1 is cancer often causes psychological injury, not mental illness. Please put in mind that the cancer patient don't need your treatment, don't need your sympathy. He need you to treat him usual, but injured person. Secondly, effective support must be stage sensitive. Every stage, doubt stage, treatment stage, operation stage, especially if he's getting the operation with Dr. Amri, okay? He needs to look, we need to deal with him that every stage has its own sensitive and even symptom-driven. 3rd point or bullet point, I will say that psychological care must protect dignity, autonomy, and timing. When I say timing, it means time limit, time according to his preference, his request, not according to our availability. No, cancer patient, they have their own time. Through that, I will answer just 3 questions because I don't want to be misunderstood. I will say if this is the diagnostic. When I say he's not ill, he's psychologically he's not psychologically ill, he is injured. I will say no. It is just a categorization needed to be forced in. Does this replacement distress screening? No. It is refining our interpretation of that case. Okay. 3rd question, is this only for cancer? No, there's too many. It's not only cancer, only burn people, grieving people for death. And I tell you, the good news is that dealing with those cases is much, much faster and easier for us than dealing with the real psychological ill people. Thank you very much. I left this one for you to go to. If you want a copy of this, I have already made a paper for it. If you want it, you can get it because I know it is a new idea, and hopefully I presented my idea very well. Thank you very much. Thank you.
Thank you. Thank you so much, Dr. Alnajjar, for this insightful talk.